Welcome to the third and final episode of our Neurology Webinar Series. Thank you to the over 1,000 of you who have registered for the event. My name is Aya Elhaj. I am the Scientific Affairs Manager at EUROIMMUN US. Today's topic will be on biofluid biomarkers for Alzheimer's disease. We will start with Dr. Stephen Arnold's presentation, followed by Dr. Aishwarya Venkataraman's presentation. And finally, we will leave about 20 minutes or so for questions, and we'll wrap it up after that. Okay, and with that said, it is my pleasure to introduce Dr. Stephen Arnold. Dr. Arnold is a professor of neurology at Harvard Medical School and the Translational Neurology Head and Managing Director of the Interdisciplinary Brain Center at Massachusetts General Hospital. At MassGen, Dr. Arnold leads the Alzheimer's Clinical and Translational Research Unit, where they conduct early phase clinical trials and biomarker research. Dr. Arnold's research focus includes neurodegenerative disease pathology, molecular biomarkers, and therapeutics, with the goal of accelerating therapeutic discovery and development. If you have any questions, feel free to write them in the chat box and they will be answered during the question and answer panel. Now I will hand it off to Dr. Arnold to begin his presentation. Thank you.
Okay, so I want to welcome everyone and express my appreciation to Aishu, Venkat, and the EUROIMMUN team for giving me the opportunity to talk about this. So to begin, these are my disclosures. And I always like to start off with grounding us in why we're here, which is to improve people's health. So I'd like to start with a case presentation. And this is a man that I saw a few years ago and have been following since. When he came, he was a 77-year-old man, well-educated, and his wife had been noticing a couple of years of forgetfulness, trouble, finding things in his office. He had always been pretty adept with technology, but he was having some difficulty figuring out new apps on his iPhone. Took a long time to do his taxes, but he, was still very functional, driving, cooking, doing home chores, taking classes. Seemed a bit more withdrawn and quiet at home. No other major medical problems other than some gastroesophageal reflux. Not much in terms of a family history of health problems, and certainly not neurologic problems. His mother did die with dementia at age 90 and had been nervous. Father did not have dementia. And on his general neurologic examination and physical examinations, there was really not much to speak of. In such a setting, we typically do a screening exam, and so on the right of the screen is a Montreal cognitive assessment that I did with the man, and he did, relatively well on, some things. You can see his clock draw, good three-dimensionality for his cube. He did have trouble remembering a number of words, so we give him 5 words to remember, and then he was only able to recall 1 out of the 5 spontaneously after a few minutes. And so, the question that a patient like this comes to an evaluation for, the questions, are really fourfold. 1, is there something wrong with me? 2, what's wrong with me? 3, what's going to happen to me? And 4, is there anything I can do about it? And so that's where our kind of evaluations and assessments really start. So, I think on the basis of this Montreal cognitive assessment and some additional neuropsychological testing, we did find that his cognition was more impaired than we might expect. Now, this is always a big question. What's the difference between, a problem with our cognitive abilities and just getting old and normal aging? And indeed, in these 3 studies that I'm showing you some very summary data for, this is a study by Denise Park and Tim Salthouse, and then some new data in green from our Human Connectome project in aging. That shows cognition across the lifespan. And, really, we all peak around age 20, and it's downhill from there. And so, but actually it's all happening within a relatively narrow range. And when we get concerned is when people fall off this curve. And when people have a noteworthy, and that's the operative word here, noteworthy decline in their memory and thinking, but they're still able to manage their day-to-day lives, we call that mild cognitive impairment. For many people, mild cognitive impairment is the first stage of a more progressive degenerative condition that ultimately goes into dementia, which is when functioning difficulties really occur because of the cognitive. But some people do just, kind of truck along in a mild cognitive impairment stage. Oops. So, we have this man. He's coming to us with complaints. He's testing out below what we might expect for someone in his age and education range. And so we have to consider the possibilities. And there's a very, very broad differential diagnosis of cognitive decline in older adults, grayed out in the background, because really the major categories are what we see in the pie chart here. Perhaps 60 to 80% is due to Alzheimer's disease, 20 to 30% is due to vascular cognitive impairment, and usually often a mix of vascular cognitive and Alzheimer's disease. Maybe 5 to 10% are Lewy body disease, 5% or so of frontotemporal degenerations, and all the other many causes are listed in the back. So, in the initial evaluation of such patients, the recommendations from the American Academy of Neurology are to look for any potentially identifiable causes, to do a few blood tests such as a B12 level, a thyroid function tests, for any kind of metabolic contributors to cognitive decline, to do some kind of neuroimaging, and this is this man's neuroimaging here, looking for any kind of major strokes, multiple strokes, tumors or blood collections or things, hydrocephalus, that could be contributing or driving his cognitive decline. And if, we rule out all these other things and there's nothing distinctive on his neurologic exam to suggest something like Parkinson's disease, then we call that Alzheimer's disease. And in good hands, neurologists would be right about 80% of the time. The definitive diagnosis of Alzheimer's disease, of course, still rests with brain tissue examination under a microscope after someone dies. And so the diagnosis is still as Alzheimer would have seen it, over 120 years ago. Look again under the microscope, and with the silver stain that was current at the time in Europe in histology, identifying the plaques and the tangles in abundance in the brain tissue that would establish the diagnosis of what we now call Alzheimer's disease. Now, fast forward, or really slow forward 120 years, we now understand quite a bit about the plaques and tangles of Alzheimer's disease. We understand that the principal component of plaques is amyloid beta, which is secreted, oligomerizes. The oligomers themselves can lead to synaptic toxicity and neuronal dysfunction, but they also tend to aggregate into the plaques, which can elicit a microglial and inflammatory response. The other major pathology, of course, is the neurofibrillary tangles. These are principally composed of tau, which tau protein, a normal neuronal cytoskeletal protein that can become hyperphosphorylated and fibrillized into paired helical filaments, disrupting intracellular trafficking, leading to neuronal dysfunction, ultimately neurodegeneration, and with the misfolded paired helical filament tau propagate transsynaptically to spread the disease in a progressive way. And these lesions, these misfolded proteins, amyloid and tau, are thought to promote neurodegeneration in the brain, ultimately. So our goal is to try to make a diagnosis, and our goal for this man that I presented really would be to make a diagnosis before looking at his brain tissue under a microscope, and that's where biomarkers come in. And we have several major categories of biomarkers now. Certainly MRI scan can be very helpful, both volumetric and functional MRI scan, to essentially track the progressive neurodegeneration and atrophy that occurs as diseases progress. Functional MRI that can tell us something about the connectivity and the functioning of the brain can be informative. The molecular neuroimaging with PET in the form of amyloid and tau, as well as fluorodeoxyglucose, are major molecular neuroimaging approaches to establishing what the pathology in the brain is in neurodegenerative diseases. EEG can be informative in some circumstances, but what we're really going to focus on today are biofluid biomarkers. So I think, understanding the role of biomarkers in cognitive decline in late life and the diagnosis and tracking of neurodegenerative dementias, it's important to understand the contexts of their use. So certainly the first thing answers the man's first and second questions is there something wrong with me and what's wrong with me? So biomarkers can be used for diagnosis. We also would like to be able to track someone's progress, so state markers to follow disease progression. Ideally, we want to be able to address his third and perhaps fourth questions, which is what's going to happen to me? So how will this progress? What will I be like? And I have mild cognitive impairment now. What will my chances of progressing to dementia be in 2 years, 5 years? In people preclinical, can we use these biomarkers to estimate disease probability even before they develop their first symptoms? Because as we know, the amyloid plaques and tau tangles start to accumulate years to decades before the first symptoms can become evident. And then can we use the biomarkers in order to track response to therapy or investigate novel mechanisms of disease? So I'm going to focus mostly in this talk on spinal fluid biomarkers. And the reason is because these have been the most informative for good reason in terms of understanding the molecular pathology and biochemistry of the brain. So cerebrospinal fluid is produced in the choroid plexi, which are tufts of blood vessels lying within the ventricles. The fluid circulates in and around the brain and is in intimate or actually direct interchange with the interstitial fluid of neurons, of the brain, so that anything that is secreted from neurons, from glial cells, or released if cells are dying, into the interstitial fluid, ultimately makes its way into the cerebrospinal fluid, and then we can retrieve this fluid, sample this fluid through a lumbar puncture in the lumbar cistern down a couple inches below where the spinal cord ends, in a simple, relatively simple office-based procedure. And that can give us a lot of information about the molecular composition of the fluid, which essentially is intimately related to the brain. And as I think most everyone knows now, the amyloid and tau are measurable in spinal fluid and have been studied since the mid-90s in spinal fluid. And in these meta-analyses, which I put here really just for visual impact, there have been many, many, many studies now that have almost totally consistently shown a difference in the level of amyloid present in spinal fluid, and particularly amyloid beta 42, the 42 amino acid form of amyloid. Many studies showing significant differences. A couple of words just to note is that, you know, the major species of amyloid that are measured in CSF, of course, are the 42 amino acid length, as well as the 40. Perhaps more importantly is the 42-40 ratio. And the reason for that is because there can be a lot of pre-analytical processing factors that can affect the levels of amyloid in the spinal fluid. Amyloid, especially amyloid 42, is a very sticky protein, so it sticks to plastics. So depending on what kind of plastics you're collecting the fluid in, transferring and all, a number of things can change the levels of amyloid. And so what we see in Alzheimer's disease is a decrease in the amount of amyloid 42, and especially the 42-40 ratio, which tends to attenuate that pre-analytical processing difficulties. And the amyloid, the reason why it is low, or what we think the reason is for its being low, is that much of the amyloid gets essentially sucked up into the aggregated form that are of the plaques that are present in the brain. The other major pathology of Alzheimer's disease, of course, is tau. And we are able to measure both total tau and phosphorylated tau in spinal fluid. And these are the major tau biofluid biomarkers that are used. The phospho-tau forms are thought to be more specific to AD pathophysiological processes, while total tau is thought to perhaps be related to Alzheimer's, but it also can be elevated in other neurodegenerative diseases and may not be as specific for Alzheimer's disease as in others, because tau, being a cytoskeletal protein, if cells are dying for any reason, tau will be released and may be measurable in the spinal fluid. So I'd like to kind of show how we've been looking at this at our study. So for the last 6 years, every person coming through the neurology service who has a lumbar puncture is asked if they would be willing to let any excess or additional spinal fluid be used in research, as well as their clinical information. And most everyone has been agreeable to this. So over the last 5 or 6 years, we are now working with a set of fluids from about 800 people so far. And I think compared to many of the other studies, which have been purely research studies, the reason why I think this may be an especially informative cohort is because it is very real world. I mean, these are patients that are being evaluated for complaints of either cognition or a very wide variety of other neurologic. So it is a fairly complicated, messy, real world cohort of individuals that we can really test the value of some of the AD biomarkers that we have for its ability to distinguish amongst these messy diseases. So I broke this down into to show you the major categories. We have people that, based on all the information available in their charts, we were able to diagnose them with either mild cognitive impairment or dementia, highly likely due to Alzheimer's disease. We do have a small cohort that we used in this study of people. These are super clean, healthy, control volunteers without neurologic illness or injury, generally very well educated, generally very healthy. We have our neurologic controls with normal cognition, and we have people with mild cognitive impairment or dementia due to a wide variety of other neurologic conditions. And I point out some of these people. So in the categories in which they fall. So for the people with mild cognitive impairment or dementia due to non-AED conditions, many of them have normal pressure hydrocephalus. There are some people with idiopathic intracranial hypertension, other neurodegenerative diseases, Parkinson's, frontotemporal dementia, PSP, cortical basal degeneration, small number with various immune conditions, some cerebrovascular conditions, and then a very, very wide variety that I just lumped together here. The normal cognition people also have a various distribution. So we do have people with normal pressure hydrocephalus, what I call CSF disorders, cerebrovascular disease, demyelinating disease. So this is a very broad mix of people with various neurologic conditions that are undergoing lumbar punctures, not systematic. And then this just is to show you the diversity of diseases that are encompassed here. So what we have done is taken this whole sample, and here's the product placement plug for EUROIMMUN kits that to first look at how the major AD biomarkers of amyloid and tau perform in this cohort. And we ran these ELISAs on a automated platform, the TCAN Freedom Evo, here with two outstanding technologists, Chris Ramirez and Bianca Trombetta, performing the work. Now, we're extremely fussy about the intra-assay, inter-assay reliability. We do a lot of vetting ahead of time in terms of even biotemporal stability. So people that have had spinal taps from, at one point and then 8 weeks later, to look at the short-term stability, how much variability is there day to day or week to week when we evaluate any particular biomarker. So we were very impressed with the technical performance of these assays. But we also like to reassure ourselves and see how they perform against other commercial platforms. So measuring A-beta 42 and 40 and phospho-tau and total tau using the EUROIMMUN kits in about 200 or 300 cases. We also ran it on the Fujiribio Lumipulse machine, Quanterix HDX that we have in the lab, and also Athena Diagnostics, which does clinical testing. And so from the patient's charts, we were able to pull what the amyloid and tau levels were. And so I think in general, we were very impressed with the compatibility and reliability of our measurement across different commercial platforms. So that was also reassuring to us in terms of our ability to interpret the data that we moved with, that we looked at in the whole group. So what did we see? So across the four groups, this is the AD MCI dementia group for A beta 40 compared to the other groups here, the MCI and dementia due to other conditions, normal cognition due to neurologic conditions, and then that ultra clean normal control volunteer. And as is typically seen, A beta 1 to 40 does not vary much amongst the different groups. A beta 42 is the most informative. It is low in people with AD types of cognitive decline, and it was highest among the ultra clean normal control volunteers, and kind of middling. These are the density plots, and as we can see, there is good separation. But where things, because of the variability of the A beta 40 and the stickiness and the variability that might occur with pre-analytical processing, there is definitely improvement in the discrimination of groups when we create an A beta 42 to 40 ratio, and we see that here with the EUROIMMUN assays. In terms of tau, we also see fairly good discrimination. These are just the raw data for the different groups between AD and dementia and MCI here. For phospho-tau here, for total tau, you can see the density plots down here. And when we actually lumped all the non-AD cases together and compared them to the AD, we did some binary classification performance analyses with ROC curves, and we were actually quite pleased with how things performed. So A beta 42/40 ratio had an AUC of about 0.93. Phospho-tau performs as well when we actually do some regression, logistic regression modeling. The fit is even better. So with 95% accuracy in this very dirty, messy group, we were able to kind of distinguish the AD-related cognitive decline from a whole mess of other neurologic conditions. So getting back to the case that they had presented in terms of diagnosis. This man had Athena Diagnostics biomarker testing. They don't report an A beta 42/40 ratio. They only report the A beta 42, but they graph things out, and he clearly was in the abnormal range for amyloid and tau pathologies, essentially establishing the diagnosis of Alzheimer's disease. So then the question becomes, okay, I've got Alzheimer's disease. What's going to happen to me? And that's where things start getting a bit messier, and where we need to improve in terms of our biomarkers. So in people with abnormal levels of amyloid and tau, and a pattern of cognitive impairment that looks like mild cognitive impairment. In these two large studies, ADNI and BioFinder, what we know is that when you are diagnosed, if you have abnormal AD, amyloid and tau biomarkers in your CSF, and you have mild cognitive impairment, you have a high likelihood of developing dementia, progressing to dementia within 6 years, but not 100%. And that's perhaps only 75%. Now that's a lot. But it raises the issue that even if your levels of these different proteins are abnormal, how do we predict what's going to happen to this man? And so I think this is where we need to move beyond amyloid and tau. So this is some data from the Religious Orders Study and Memory and Aging Project conducted at Rush. I was affiliated with them for quite some time as a collaborator. And looking at the general, neuropathological quantitation of plaque and tangle pathology in relationship to someone's cognitive abilities, clearly the more AD pathology you have in your brain, the more cognitively impaired you are. These are Z-scores here. But even at the time of death or shortly before, people can have very high levels of AD pathology in their brain, plaques and tangles, with Brock stages of 5 or sometimes even 6 for tau pathology, and yet be performing in the normal cognitive range. So there's a lot of heterogeneity in Alzheimer's disease, heterogeneity of the degree to which the signature pathologies actually correlate with the cognition. There's heterogeneity in the way cases can progress, so that some people may remain with a head full of plaques and tangles, relatively cognitively normal for a number of years, other people having a slow decline, other people having a more rapid decline, and other people falling off a cliff. This person perhaps developed a stroke, I'm not sure. We also recognize, this is also from the Religious Orders Study and Memory and Aging Projects, that people can have as many diseases as they want. And the majority of brains do exhibit mixed pathologies. So there's heterogeneity of pathologies. AD, amyloid, plaques, tau tangles may be, common, but it's hard to find brains that don't have some degree of vascular, cognitive, vascular disease, Lewy bodies, TDP-43 lesions as well. And then the other reason why I think we need to learn from some of the recent anti-amyloid trials, but the other reason why we need to move beyond amyloid and tau in trying to understand people's diseases and the heterogeneity of the diseases is coming from the aducanumab trial and some of the other trials that are, aducanumab is an anti-amyloid immunotherapy. It's a very effective drug. I would say, in terms of its ability to decrease the amount of amyloid present in the brain. This is showing people at baseline, and then after 1 year of treatment with aducanumab, showing a marked dose-related reduction in the amount of amyloid in the brain. It even seems to be engaging the whole disease process by reducing the amount of tau that's present in the brain with treatment of amyloid, and reducing levels of phospho-tau in spinal fluid. And yet, despite the effectiveness at engaging the disease pathology that we think is at the basis of Alzheimer's disease, people continue to get clinically worse. So, and maybe there's a little bit of a difference in terms of the rate at which they are getting worse, but they are still progressing. So obviously, to me, what this seems to show is that amyloid and tau may be important drivers, but they are not exclusive drivers. and we need to do better in terms of understanding how the disease progresses. So I think that this is a bit of a complicated slide for us today, but I think that we are moving beyond the amyloid and tau in Alzheimer's disease to appreciate the many drivers of disease. There are a number of risk factors that lead to Alzheimer's disease type dementia or other dementias more broadly. These travel through a variety of pathophysiological processes, whether it be vascular injury and neuronal ischemia, inflammation and immune response, mitochondrial dysfunction, oxidative damage, and all of these things, while we focus in on amyloid and tau, but all of these things function in vicious cycles. And this is kind of intimidating at first, but also interesting in that it may allow many different entry points in order to affect these vicious cycles that we have. So I think there's a need for biomarkers, one, to understand, some of the other protein misfolding pathologies that co-occur with Alzheimer's disease pathology more than you would predict. So alpha-synuclein pathology, TDP43 pathology, and I'm not going to get into this here, but there is some progress, but I would say still not enough progress for our ability to detect these with biofluid biomarkers at present. A lot more work needs to be done. Similarly, in order to track the disease, we need better biomarkers for neuronal degeneration, synaptic degeneration that may correlate better with the degree of cognitive impairment in people beyond amyloid and tau. One of these that is interesting and everyone's favorite right now as a general marker of neurodegeneration is neurofilament light chain. This is a intermediate filament cytoskeletal protein that with a relatively long half-life that when axons are degenerating is released into the spinal fluid and a little bit actually gets out into the blood. And it appears to be elevated in many diseases, Alzheimer's disease, but it's a general considered a general marker of neurodegeneration. And I think there's still that we're learning a lot about neurofilament, particularly its usefulness in a longitudinal fashion for predicting rate of degeneration and predicting future decline. Synaptic markers, I think, are going to be even more important, and we do have some that we're working on. So, while neurofilament or tau protein can be released as axons and synapses, and neurons are dying and degenerating, they can be released into spinal fluid. A number of pre and post-synaptic biomarkers may be just as, or perhaps more informative. We need to know that. Neurogranin is one of them that has been looked at now for a number of years. This is highly enriched in dendritic spines, so postsynaptic, as a postsynaptic marker, and it does appear to be elevated in Alzheimer's disease, as considerably more so than other neurodegenerative diseases. We've just started to look at this in our group with about 150 cases. We used the EUROIMMUN assay, looking at our AD and dementia and MCI group compared to other MCI and dementia and our normal control volunteers. We do see that it is elevated. We also used the Quanterix SNAP25 assay, which showed something similar. And we were, again, given our interest in sort of cross-platform consistency, we were very pleased to see the degree of correlation between the presynaptic SNAP25 marker and the postsynaptic neurogranin marker, giving us a lot of reassurance and confidence that we were indeed measuring the amount of synaptic protein that's detectable and floating around in the spinal fluid. Again, I'm not going to be able to get into this now, but the issue of inflammation and immune response and the need for better biomarkers for those, we do have some that are good. YKL40, GFAP appears to be getting better and better, perhaps STREM2. These are important biomarkers that are measurable in spinal fluid and perhaps some in blood. Vascular injury markers are another thing that for which there's, I think, a great need in our ability to understand how they perform both CSF and blood. I'm just going to end with a few words about the challenges of developing blood-based biomarkers, because of course this is the holy grail. We would love to have a blood test and not have to do a lumbar puncture, but there's a lot of challenges in developing this. You've got about 20 milliliters of spinal fluid that's turning over per hour in the brain, and that is getting absorbed by arachnoid villi and being diluted into 5 liters of blood. So, you know, the ability to detect CNS-specific proteins in a huge ocean of blood that in itself is being, turned over, filtered by the liver, filtered by the kidney, is really, I think, the major feat that we're trying to overcome now. But there is progress being made. Neurofilament light is one of the proteins that, again, I think partly because of its half-life and stability, does leak out into blood and can be measured. And there are now many studies that have, are showing good, I'd say not great, but good accuracy for distinguishing different types of dementia, certainly AD dementia versus normal controls, but we're also learning more and more about their performance among other neurodegenerative diseases. This was a nice study looking at plasma biomarkers for tau and neurofilament light. This is from the Columbia group, and I like this because it was really quite a diverse group of individuals, Latinos, African Americans, and Caucasians from New York. And as you can see, these ROC curves, we do find that in the autopsy cohort and less so in the clinical cohort from this study, there was actually not bad discrimination in when you're looking at autopsy verified diagnosis, reasonable accuracy, okay accuracy, for tau and neurofilament light and p-tau. A-beta 42/40 ratios do not tend to perform well in blood. We're starting to look at this in our own sample here, our MIND cohort. A-beta 40, the correlation between A-beta 40 levels in spinal fluid with matching plasmas from our sample is pretty poor. A-beta 42 is okay. The ratio, I think probably because of what we see, the difficulty with 40 measurements in blood, the ratio doesn't really add much, or it actually doesn't add anything to what we get from A-beta 42 levels in plasma versus CSF. We did a little bit of, and this is very preliminary analyses, but we did a little bit of ROC analysis looking at A-beta 42 and its ability to discriminate the AD-related MCI and dementia group from the non-AD, all the rest of the controls. And interestingly, we got a little bit better than what I've seen in the general literature here. So an accuracy of about 70%. We do better looking at plasma p-tau and neurofilament light in our ability to discriminate these groups in this in our mind bank. And so, I think that this is all very promising, and we need to kind of expand it to really understand it much, much better. So I'm going to end with that. Just as a shout out, pre-pandemic shot of the group. We're actually larger now over the last year. And I want to thank you all for your attention and turn it over to Aishu.
All right, thank you, Dr. Arnold, for that fascinating presentation. It's amazing to see how far we've come and how far we still have to go in terms of research and development. And now it is my pleasure to introduce our second speaker, Dr. Aishwarya Venkataraman. Dr. Venkataraman is the Scientific Affairs Lead at EUROIMMUN US. Among the many hats she wears in her role, she builds scientific partnerships with healthcare professionals to promote medical diagnostic activities. Dr. Venkataraman holds a PhD in neuroscience. During her PhD, she identified novel autoantigens in autoimmune hyperexcitability disorders. She is an inventor and holds a patent for identifying soluble NSF attachment protein receptor, or SNARE, in patients with selected autoimmune neurological disorders. And today she'll be discussing some of the commercially available assays in neurodegeneration. So Dr. Venkataraman, the floor is yours.
So thank you, Aya, for the really nice introduction. And also thank you, Dr. Arnold. That was a really amazing presentation, very insightful, covering all the biomarkers in this particular neurodegenerative condition. So over the next 10 minutes, I'm going to be really quick. I'm going to talk very briefly about EUROIMMUN and the various assays that we have for measuring biofluid biomarkers in neurodegenerative conditions. EUROIMMUN is a medical diagnostic company. We are headquartered in a small town called Lübeck in northern Germany. We pride ourselves for producing state-of-the-art technologies and assays for detection of various autoimmune conditions, infectious diseases, including COVID, allergy, and also assays for measuring biofluid biomarkers in neurodegenerative conditions. So when we look at the global evolution of biomarkers, especially in neurodegenerative conditions, particularly Alzheimer's disease, I think Dr. Arnold really nicely mentioned that only in the early 90s is when scientists and researchers started really looking into biomarkers in biofluids like the CSF. I would say like the major breakthrough in this field happened between 2005 and 2015, where biomarkers really got the front stage, meaning biomarkers were beginning to get implemented in the research criteria for Alzheimer's disease since 2011. And in 2016, the ATN profile classification system was developed. In 2017 is when we had a certified reference material for beta amyloid 42. And in 2018, a very good publication was released, which was the research framework, which actually mentioned that there is a paradigm shift in the definition of Alzheimer's disease, changing from a syndromal perspective, changing from a clinical perspective to a more biological definition, meaning through measurement of biomarkers. So I think this changed the way people started looking and detecting Alzheimer's disease. So we all can agree here that a definite diagnosis of Alzheimer's disease can be achieved only post-mortem. However, we are all, including researchers, scientists, and clinicians, are trying to better understand a probable diagnosis of Alzheimer's disease based on biomarkers, especially the imaging as well as biofluid biomarkers, which is in the CSF and blood. So the evolution of biomarkers at EUROIMMUN is somewhat similar to how things happened globally as well. We started looking at the requirements and the needs of researchers and scientists to measure these biomarkers in biofluids. So we developed very robust, reliable assays that can help these scientists to measure biomarkers. So this started happening since early 2010, and as of 2013, we released our first assay to measure beta amyloid 42 and 40 in the CSF. And as the years progressed, we added more and more to our portfolio in terms of biomarkers, such as, we included the ATN profiles itself very early on. We have the total tau, the phospho-tau 181, neurogranin, and recently also the neurofilament heavy chain, which I'll talk about in a short time. As of 2019, we've also included alpha-synuclein measurement, which can be helpful in Lewy body dementia. So Dr. Arnold spoke really nicely about the biomarkers and the various studies that he's done. So I'm just going to take a very quick minute to talk about these biomarkers and what is known from scientific publications or what scientific data is already available. So as we have already discussed, from the beta amyloid perspective, we recommend measuring the CSF beta amyloid 42 over 40 in Alzheimer's disease. And again, Dr. Arnold also mentioned this, but the ratio is kind of is not influenced by external factors such as the tube types or the volumes of CSF that you add, or by freeze-thaw cycles. So because of that, we prefer the ratio over individual biomarkers for analysis. And this paper right here actually talks about the correlation between the biomarkers and another biomarker, which is the imaging, the PET image. And it's shown here that the concordance to PET imaging increased to 93% when you're looking at the ratio of beta amyloid 42 or 40 in the CSF compared to the individual biomarker. So hence, it shows the improved significance or the improved potential of this ratio having a very good correlation to PET imaging results, and hence can be possibly used as a suitable alternative. So I mentioned about certified reference materials earlier. So EUROIMMUN assays are recalibrated based on the certified reference materials for beta amyloid 42. This data has been published as well. But just to give you a small snapshot, so if you take a look at the figure below, so if you see the areas where it's marked original, so this is the CVs or the variation between different assays prior to recalibration with the CRMs. So it's about like greater than 20%, which is quite a lot. So following recalibration of the test systems using the CRMs, you can see how the CVs reduced to less than 8%. This shows that certified reference materials have a very good potential and is valuable for harmonizing and standardizing test systems that are commercially available. We are hoping to have more certified reference materials for other biomarkers such as beta amyloid 40, the p-tau, total tau, etc. So coming to a real world setting, at EUROIMMUN, we also participate in a lot of quality assurance schemes. This one is from the Instant Quality Scheme from Europe. And to direct your attention to the graph on the right side, so when you're looking at various biomarkers, EUROIMMUN and one other competitor performs quite similar. But I want to direct your attention to this biomarker, that is the beta amyloid 42 over 40 as a ratio. And here you can see that the assay performance of EUROIMMUN, where you see that the percentage agreement to the quality control samples is about 87%, whereas for the competitor it's about 73%. So once again, showing a superior assay performance of EUROIMMUN assays for reliably measuring the beta amyloid 42 over 40 ratio. So Dr. Arnold also covered very nicely about about the significance of blood-based biomarkers and also some of the blood-based biomarkers that he's included in his study. But I want to talk a little bit about this study that recently came out in 2020, where the authors directly compared an ELISA platform to a high-sensitive immunoassay that's a Simoa platform. Again, everybody in this audience is like, when you talk about blood-based biomarkers, you immediately think you need a high-sensitive immunoassay. So I think this study will be really helpful for you to clarify a lot of things on that perspective. So this study included about close to 200 odd study population non-demented controls, which includes both control groups as well as a small cohort with amnestic MCI. And then the authors measured plasma levels of beta amyloid 42 over 40 and correlated them to the PET amyloid status of these patients. So on doing the ROC curve analysis, as you can see from the image below, and if you see here, you can see that the area under the curve for any assay that you take, either the ELISA or the Simoa platform, is almost comparable irrespective of the cohort that you're looking at. So if you're looking at the entire study population, it looks very comparable. And also when you're looking at the amnestic MCI population. This kind of shows that there is an equivalent performance between an ELISA test system and a Simoa platform for measuring plasma amyloids, especially the beta amyloid 42/40. This paper goes ahead and also talks about, or has plotted, the sensitivity and specificity of both the assays. And once again, both of them are very comparable. So one thing as developers, we always keep in mind that when you're looking at blood-based biomarkers, you want to keep in mind that in the long run, in the near future, you want to use them possibly as a screening tool. That way, it should mean that they should have a very high negative predictive value, meaning you're not going to subject the control population or the cognitively normal population to go ahead and get tested for another expensive or a very invasive confirmatory test. So you want to make sure that the test systems has a very high negative predictive value, and that's something what our ELISA test systems have also shown, as you can see in this slide. And the positive predictive values can be lower because you're ultimately going to do further confirmatory tests for this, this set of conditions. Overall, this study demonstrates that the accuracy of determining PET amyloid status in non-demented population through the measurement of beta amyloid 42/40 in the plasma was very similar between the ELISA and the Simoa platform. So therefore, if you're looking or debating which system to go for, based on this publication, it is possible to still start your analysis using the ELISA test system, and you're going to find very similar test results. Okay, so I'm going to slightly shift gears here a little bit in the last couple of minutes from Alzheimer's disease to amyotrophic lateral sclerosis. ALS gained huge popularity during the Ice Bucket Challenge, if everybody remembers. So ALS is also another neurodegenerative condition. It is a motor neuron, it's progressive degeneration of the motor neurons. And in ALS, typically what happens is that following axonal injury, there is release of certain biomarkers or protein markers into the biofluids like CSF and blood. One such protein is the neurofilaments, and the neurofilament typically you can have the neurofilament light, as well as the other one is the phosphorylated neurofilament heavy chain, and I'm going to be talking a little bit about this particular biomarker. So as you can see from this levels, the neurofilaments levels are slightly higher in the CSF compared to blood, as you're familiar that it's, once it passes through the filtration process into the blood, you're going to achieve only lower concentrations here. Nevertheless, there's been a lot of publications that has already been published showing very good correlations between the CSF as well as plasma levels of phosphorylated neurofilament heavy biomarker in ALS. So today I'm going to divert your attention to this one particular publication. So in this publication, the authors measured serum levels of phosphorylated neurofilament heavy, and they observed that these levels were elevated up to 18 months prior to a diagnosis of ALS. So as you can see, this means that it can be a very promising, possibly diagnostic biomarker for this very fatal, crucial condition. Additionally, this paper also further talks about how this biomarker can also be used as a possible prognostic biomarker. So once again, I would definitely encourage, if you're in the field of ALS, to go ahead and check out this particular publication. So with that, I'm going to come to the end of my presentation. Just talk about the broad portfolio of biomarkers that is available from EUROIMMUN, starting from the beta amyloids and tau for Alzheimer's disease, to neurogranin and neurofilament heavy chain for ALS, and alpha-synuclein for Lewy body dementia, which can be measured in the CSF and some in the blood as well. So more or less, we have a very comprehensive portfolio for measuring various biofluid biomarkers for neurodegenerative conditions. With that, I come to the end of my presentation, and thank you again for this opportunity, and I'm happy to take any questions. So over to you, Aya.
So that concludes our presentations from both speakers. And at this time, I'm going to hand it off to Dr. Ilana Heckler to start our question and answer panel. Thank you.
So thank you everyone for your questions. We received quite a few, and any questions that we do not get to live will be answered via email. And so the first question that we have is for Dr. Arnold. Angela asks, have you seen any evidence of increased CSF amyloid beta 42 prior to decline?
Yes, I mean, I think that there's fairly good evidence that changes in A beta levels can precede by years the onset of Alzheimer's disease. I think the longitudinal studies are really the most critical that we need to be doing, and that prediction. But yes, I mean, we know that there's amyloid changes in CSF that are highly predictive of the amyloid changes that can be seen in neuroimaging, and that both of those are predictive of markedly increased risk of developing clinical disease at some point in the future. Hard to predict when, and that's why I think I was arguing for more biomarkers to kind of really fill that space in.
Great, thank you. Next, for Dr. Arnold, Dr. Patrick Griffith asks about the race and ethnicity of your cohort.
Yeah, so we are about 84% Caucasian, and then the rest is a very broad mix of probably, mostly African Americans, Latinos, smattering of other races and ethnicities.
Okay. And for Dr. Arnold, Shobha asks if you could comment on which p-tau isoform, either 181, 231, or 217 was used.
Yeah, so we used the, it was p-tau 181 in our studies. And there's a lot of buzz right now about 231 and 217, and whether one is, because there are now assays emerging for those phospho isoforms. And I think the jury's still out. I think my inclination is that they're all ultimately going to be pretty equivalent. And it all depends on the sensitivity of the assay and the, how low a level it's able to detect, as to whether it's going to be, useful from a clinical or research perspective.
Great. This question could be, I suppose, answered by either speaker. Angela asks, are there any salivary biomarkers?
I don't know if...
So that's a really good question. I guess, already the world, I would say the community is struggling with blood-based biomarkers. I have not seen any publications as yet on salivary biomarkers, but I could be wrong because there are people looking into the retina for Alzheimer's disease for biomarkers. So personally, I want to say this, maybe Dr. Arnold can chime in, but I think we are in a step where we're really good stage for CSF biomarkers, but we need to do the same for blood-based biomarkers before we go ahead and look into the other biofluids. So we need certified reference materials. We need more publications to talk about which biomarkers we can use. So similar stand that the CSF biomarkers have taken, I think needs to be followed first for blood-based biomarkers.
Yeah, just a comment about, so it is very interesting, and I think that saliva is an interesting biofluid that we can, tap into. But just a little bit of caution with that is that, it sounds like easy just to spit in a tube and then run your assay, but it ain't like that. The way you collect it, there are different methods, and it's actually harder, especially for older people, to generate saliva that's meaningful a blood test actually is easier. The question is saliva as being a simpler fluid, is there something more informative about that? So, those are some of the considerations.
Great. So for Dr. Venkat, somebody asks, you mentioned about 2018 research framework for biological diagnosis of Alzheimer's disease. Do you think that diagnosing patients by biomarkers is needed for clinical trials in Alzheimer's disease?
Okay, so the first thing I want to correct that question, or maybe in case I mentioned it. So the research framework mentions at least about 3 times in that publication that this is only for observational studies. It is not yet ready for clinical diagnosis as yet. So this will answer your second question. So if you're looking at a clinical trial, or if you're looking for a study, definitely you want to look into what the publication talks about, the ATN profiles and what biomarkers you can use. And that way it could be a really good inclusion criteria for your clinical study. But for diagnosis, the publication says that it is probably the community is not yet ready, but it can aid in it. So this is only for observational studies.
Okay. Okay, so a question for Dr. Arnold. Are there known biomarkers that indicate or predict resilience or correlate with minimal cognitive decline despite a heavy plaque tangle burden?
Not, I mean, I think there are biomarkers of interest, but nothing really established. The whole issue of whether resilience is an active process or just kind of like a passive process, that there's not as much neurodegeneration going on per unit of amyloid or p-tau pathology, that I think we're still struggling with. And so you could argue that someone has high amyloid and maybe even high phospho-tau, but their total tau or neurofilament light or neurogranin levels are low. And so is that a biomarker of resilience because they're not having as much neurodegeneration going on? We don't know the answer to that yet. I think even a more interesting question is, and this is why, again, to kind of fill out and look for other drivers of neurodegeneration in the face of amyloid and tau. The inflammatory markers, the vascular injury markers, oxidative stress markers, if we had them. Those I think would be very interesting for us to understand how the brain is responding to the presence of amyloid and tau pathology in the brain. It's a really interesting point.
Thank you. I have the next question could be answered by either speaker. Edward Jackson asks, do you think that single molecule array technology is the way forward for blood biomarkers?
Maybe Aisha can pick up. I think it's one way. There are different microfluidics. Again, it all depends on what the sensitivity and the precision of your assay is. If you've got really good antibodies, or to detect low levels and very robust assay, you may not need the microfluidics of Simoa or some of these other techniques. So yes, it is one way. It does work well. We've seen that, but there are other ways. Aishu, do you add to that?
Yeah, I think you have covered it very perfectly, really well said. So all I would say is there's more and more studies that are coming out that are doing like nice comparisons between an ELISA test system and a high sensitive immunoassay. I've shown one during the webinar. So this showed pretty much comparable assay performance between both the assays. So like Dr. Arnold said, it completely boils down to if your assay is performing equivalent, then it just comes down to what is possible for you to start with. ELISA systems are readily available, easy to use, it's inexpensive compared to a very high expensive instrument. So once you have that data set in your hand, it completely comes down to the researchers which one they want to move forward with.
Yeah, and let me just add another point, and that I think there's an important role for automation in the performance of the assay too. I mean, it really does, when you've kind of worked out an automated platform, to run the assay, it really does enhance the reliability and kind of attenuate the, unavoidable human error that might occur with pipetting or transfers or things like that.
Great, thanks. Next question for Dr. Arnold. Could you comment on the blood-brain barrier in terms of measurable biomarkers in serum and how that might also contribute to neurodegeneration pathology?
Yeah, so blood-brain barrier breakdown is a feature in Alzheimer's as well as many neurologic diseases, and it appears to be variable. And I worry about it actually both ways, in terms of measuring, CNS specific proteins in the blood, as well as measuring other things in the spinal fluid. So if we're measuring inflammatory molecules or other molecules, and there's blood-brain biomarker, blood-brain barrier breakdown, is someone's interleukin X elevated because it's just the blood-brain barrier is broken down, or because it is being produced in the brain at high levels. So I worry about it in both ways, and I think the data will just have to kind of accumulate. There's going to be noise in blood where I think if we can get into the 80% predictive range, I think we should be cheering. We'd like to be 95 and up, but I'll take 80 for blood. And I think also, as Aishu mentioned, the importance of the blood is for, I think is for screening. And, it's a way to enrich your confidence in the diagnosis, but for some circumstances you're going to need to confirm it with a better biomarker, whether that be CSF or neuroimaging.
Thank you. So this question could be answered by either speaker, possibly Dr. Venkat. Someone asks, how would you explain the higher diagnostic accuracy of plasma NFL for Alzheimer's disease versus non-Alzheimer's disease dementia compared to amyloid beta and p-tau, considering that neurofilament light is viewed as a non-specific marker for neurodegeneration, while p-tau and amyloid beta are supposed to be Alzheimer's disease specific?
Right. So if I got that question right, is the question talking about how are you including NFL as one of the biomarkers for Alzheimer's disease, because even though it's non-specific, right?
Yeah.
I hope I've got that. So I'll also let Dr. Arnold answer this question because he's done a lot of studies with NFL, but my experience is just, once again, based on publications. We don't yet have an assay for NFL, but that's something we are working on. So as you've mentioned, NFL is not a specific biomarker. It's a marker for neurodegeneration as it is. So if you look at the ADN classification system, which I kind of bind to, that would fit possibly in the N criteria. So you still need your amyloids and tau if you're looking for Alzheimer's disease. But I've read some publications that it is also useful for frontotemporal dementia differentiation to Alzheimer's disease. So possibly in that avenue as well. But I'll let Dr. Arnold comment more in terms of diagnosis.
Yeah, I mean, I think I'll just say I don't really understand it myself. So neurofilament light does appear to be, elevated in a range of neurodegenerative diseases. For some reason, this is the things that we're still trying to understand. FTD, frontotemporal dementias, the NFL levels seem to be a little higher than in Alzheimer's disease. Other dementia with Lewy bodies, even though these diseases seem to be progressing perhaps at similar rates, so the rate of neurodegeneration going on, there do seem to be differences in the amount of NFL that's released in AD versus FTD versus Lewy body disease, and I still don't quite understand that. Similarly, the issue with tau and total tau. So total tau has often been considered as a more general marker of neurodegeneration, because it's elevated in rapidly progressive dementias like Creutzfeldt-Jakob disease, people with traumatic brain injury in the acute phase, stroke in the acute phase. So if there's brain, pathology, brain degeneration or injury going on, tau gets released and you can measure elevated levels. Well, half of frontotemporal dementias are tauopathies. Other conditions like progressive supranuclear palsy or cortical basal degeneration, these are also tauopathies, and yet we don't see elevations in total tau so much in those compared to AD. We see it in some cases, but not others, and then so I'm still confused by it myself. That's all I have to say.
Great, thank you. We had a question by email for Dr. Arnold. When you talk about aducanumab clearing amyloid beta, do you know the mechanisms? Is it through coating amyloid beta and then Fc phagocytosis by macrophages?
These are well, I'm not an expert on all that happens, but these are antibodies directed at amyloid beta. So basically, they're sequestering amyloid beta, and then it gets chewed up by microglia, presumably.
Great. Another question about aducanumab, possibly either speaker could answer. Should aducanumab be approved, will CSF assays be sufficient to confirm brain amyloid versus PET?
So I don't know. That'll depend on Biogen and the FDA. I think you do want to have confidence that there is amyloid and Alzheimer's disease in the brain, and to my reading, if we, the data for spinal fluid, amyloid and tau levels is just as good as the amyloid PET imaging, and so to me they're equivalent, and they would both be acceptable as long as the assays are, rigorous and approved for clinical use.
Great. Another question for Dr. Arnold. Ashwin asks, can you please tell us your opinion on potentially using elevated concentrations of metals, for example, copper, iron, zinc, as a biomarker for increased levels of amyloid?
Yeah, so that's been an interesting, long-standing kind of scientific interest in the field, because some of the metals really can facilitate enzymatic action, and may be important in terms of processing or changing the rate of processing of some of the proteins and promoting misfolding and all. I just don't know the literature well enough to know what whether measuring levels of copper, zinc, whatever, how well that correlates with some of the more established markers.
Great.
Not much of an answer, but that's what I got.
Okay, so another question, Dr. Venkat, possibly you can answer this. Someone asks, what are the differences in the use of light NF versus heavy NF?
Yeah, so I was waiting for somebody to ask that question. So neurofilament light, like again, Dr. Arnold mentioned in his studies and also about publications, pretty much a biomarker for general neurodegeneration, looking into more like for frontotemporal dementia, it's slightly higher compared to Alzheimer's disease. Whereas phosphorylated neurofilament heavy, I would say, is clearly a biomarker in the direction of motor neuron diseases like ALS. So there are a lot of publications, there's a lot of clinical studies that have been done that show that increased levels of PNFH are observed in patients with ALS compared to other neurodegenerative conditions, as well as ALS mimics. That's also a clinical symptoms, right? So again, phosphorylated neurofilament heavy is significantly increased in ALS compared to the other cohorts that you look into, and all the publications talk really nicely about that. And the amazing thing is they correlate really well between the CSF and blood compared to what we've seen in amyloids, which is a little bit different. So, and you don't need a very high sensitive instrument to do any of that. It's sufficient with an ELISA system to measure really well the blood-based or serum-based levels of this biomarker and then confirm using the CSF levels. So again, long story short, will be NFL more in the line of neurodegeneration, general neurodegeneration like FTD, AD, and others, whereas neurofilament heavy more in the direction of ALS and predominantly ALS. That's what I would say.
Sounds good. Another question for Dr. Venkat, possibly. Alessandro asks, is there any other post-translational modified amyloid beta peptides detectable in the CSF, for example, nitrosylated? And is there any potential for these post-translational modified peptides to be used as biomarkers?
I think that's a really interesting question. Honestly, I've not come across other post-translation modified biomarkers that have been shown to have a clinical utility or at least an analytical utility in Alzheimer's. But Dr. Arnold, any other thoughts? If you have come across other?
For amyloid, no.
Yeah, no.
You know, there are different, people are looking at amyloid, 1 to 42, 1 to 40, 1 to 37, 1 to 43, and, we'll see how that evolves. But, some species may be more informative than others. They have a ways to go to be established and understood.
Great. So we'll just end with one more question. Can you predict the evolution from MCI to Alzheimer's disease?
Within degrees of probability, yes. Absolutely no. And like with my patients, I still say I've given up trying to predict who and when is going to progress, because I've seen some people that need nursing care in 2 years, and I've seen other people that start at the same rate or start at the same point, and they're still going on vacations and skiing with their family 15 years later. That's why I'm saying that we need better biomarkers to kind of enrich what amyloid and tau tell us.
Great. Thanks so much.
Dr. Arnold, I guess I may add in a comment here, but also with what we have as biomarkers, possibly, do you think there's a value to longitudinally monitor them once you start seeing the clinical, condition in terms of an MCI? Maybe we start monitoring them through the ATN profile, and that way we have a understanding of probability to progression. What are your thoughts on that?
Yeah, so I think the A and T are pretty well investigated, and they don't seem to provide much prognostic value. It's the N, and that N is a big N because it can encompass, synapses, neurofilaments, a whole other things. And I think, filling out beyond ATN, what about I, which is inflammation? What about V, which is vascular? Those are the things that I think will inform us more about prognosis, because we've pretty much looked at amyloid and tau in themselves, and they aren't good enough for predicting the future in the course.
So maybe more biomarkers, the better. So evaluating more and more biomarkers.
We need to increase the number that we have and what their relative values are.
Got
it's
it.
a complicated piece.
Absolutely, yeah. So with that, Ilana, I'll hand it over back to you. We're close to our time.
Yep. So any questions that we did not get to live will be responded to via email. And thank you all for your questions. They were really great. And I'm going to now pass this over to Dr. Alhaj to close us out.
So this concludes our Neurology Webinar Series. On behalf of EUROIMMUN Academy, thank you everyone for attending today's webinar. We truly appreciate the support and interest from everyone in the audience. Please be on the lookout for the next webinar on June 3rd, which will be on dermatomycosis. Lastly, if you are interested in being a speaker and are based in the United States, please reach out to us at scientificaffairs@euroimmun.us. Thank you all and enjoy the rest of your day.